So we will go ahead and call this meeting of the Texas State Board of Pharmacy to order. As is our tradition, we always start with our mission statement to ground us and to remind us of our duties. And our mission statement is that the Texas State Board of Pharmacy, as a leader in protecting the public health of the citizens of Texas, shall uphold quality standards for licensing and facilitate regulation that promotes innovative, multidisciplinary, and collaborative practices and education which produces quality care and positive patient outcomes. Just as a reminder, we, as far as board members, make sure that when you go to speak, you're turning your microphone on and off so that everyone can hear us. And then there are QR codes with the agenda posted in the room. The Wi-Fi password is available on the screen on the wall behind Lily. And we always thank Lily for all that she does because she keeps us honest and everything going. And with that, I will turn it over to Danny for roll call.
Thank you, Julie. Donna Montemayor. Here. Donnie Lewis. Here. Rick Fernandez. Here. Haisha Freeman. Present. Stacy Hightower. Randy Martin. Here. Ian Shaw. No Ian. Suzette Tijerina. Here. Rick Tish. No Rick Tish. And Jenny Yoakum.
Here.
Thank you.
Okay, we will show Ian absent, and I know that Rick is almost here, so we will amend the roll call once he comes in. Attendance of today's meeting will grant a total of 3 hours of CE, which can be counted as the Texas-specific pharmacy law or as general credit. As is the rule, you have to be here for the whole meeting to obtain that CE, and the QR code will be posted later along the exits as you leave. With that, we will start the actual meat of the agenda. Board members, the first thing is the minutes, as is our policy and case. The minutes were sent out to you prior to, and you've had the chance to review them. Are there any corrections to the minutes? And if not, if I can have a motion to accept. Donna has made a motion to accept. Do I have a second? I have a second over here from Jenny. All those in favor of approval?
Aye.
Any in opposition? The minutes are passed. With that, I'm going to turn it over to Mr. Griffith to go through our one rule for adoption.
Thank you, Madam President. Board members, in the rule PDFs you've been provided, there are bookmarks with links, the lines with edits. And for the rule for adoption, you've received copies of the order and preamble in the OneDrive link that was sent to you. Also, you have them on your computers. So the rule for adoption was proposed at the February 3rd, 2026 board meeting and published in the March 27, 2026 issue of the Texas Register. And on your agenda, it's C1.1. It's new rule 291.13 concerning telehealth services provided by a pharmacist. This is a new rule, if adopted, would establish the documentation and retention requirements regarding a patient's consent to treatment, data collection, and data sharing to telehealth services provided by a pharmacist. This is all in accordance with House Bill 1700. So going down, looking at lines 50 through 51, it defines telehealth service. Shall the meaning defined by the Texas Occupations Code, section 111.0013. Lines 52 through 53 provide that the requirements of subsection C of this section apply to a telehealth service regardless of whether the patient interaction occurs in a video or audio-only format. Lines 54 through 57 provide that a pharmacist who provides telehealth service shall obtain the informed consent of the patient or of another individual authorized to make healthcare treatment decisions for the patient before the telehealth service is provided. The informed consent may be obtained either in writing or verbally. Lines 58 through 61, the informed consent shall include the patient's consent to treatment, data collection, and data sharing. On lines 62 through 66, the informed consent shall be documented by recording the initials or identification code of the pharmacist to obtain the consent as follows: in the pharmacy's data processing system, in an electronic logbook, or in a hard copy log. And then on lines 67 through 74, it provides that documentation of informed consent shall be kept at the pharmacy's licensed location and be available for at least 2 years from the date of such record for inspection and copying by the board or its representative, and to other authorized local, state, or federal law enforcement agencies, and supplied by the pharmacy within 72 hours if requested by an authorized agent of the board. Failure to provide the records either on site or within 72 hours constitutes prima facie evidence of failure to keep and maintain records in violation of the Act. And board members, we did receive 2 comments regarding this rule. The board received a comment from Jessica Kovaci, Farm D with Albertsons Companies, suggesting clarification of the term telehealth service to exclude routine pharmacist-patient communications occurring as part of dispensing, patient counseling, medication adherence, outreach, or other activities within the practice of pharmacy. The board also received comment from Rob Geddes, Farm D with CVS Health, suggesting clarification of the term telehealth service to exclude routine telephonic interactions incident to the dispensing of a prescription, and that a single instance of a documented informed consent may apply to ongoing or repeated telehealth services involving the same condition, course of treatment, or type of service. And those were all the comments.
All right. Before we get to our discussion, if we would go ahead and make notation that Rick Tisch is here. So our only absent is Ian Shaw. All right, board members, questions, comments, answers, a motion?
I do have one comment and something that I'd like to see if we could modify. So the language as written, if I'm interpreting it correctly, is that the pharmacist must personally themselves obtain the consent. And so a lot of times if we have pharmacists that are practicing as part of a collaborative practice agreement or something similar, they're in a medical office. And so those consents are obtained electronically. They're sent to the patient electronically and they sign those. There's not really a mechanism for a pharmacist to acknowledge those. Alternatively, a verbal consent may also be obtained in other settings by a medical assistant or someone similar. We see the same thing in telehealth practices with pharmacy. So I'd like to see if we could, I don't know if we would say, and it may not necessarily be a pharmacy tech, it could be a pharmacy tech, it could be a medical assistant, it could be a nurse that would be obtaining that consent. Or it may be a similar consent if they've already received telehealth services within the same organization. They may have already obtained that consent in a previous visit and it wouldn't have been obtained by a pharmacist because it's a generic telehealth consent to apply to all types of services. So I would just say pharmacist or agent or something similar that would kind of align to what's actually happening in the world.
Would that be substantive or?
I think that'd be fine.
Other questions, comments? Yes, sir. Rick.
Megan, the clarification requested by Albertsons on the routine dispensing communications, do you think that is something worth considering or is already included in it?
So the request by Albertsons, I don't believe that's something we can do. We don't have the authority to narrow a statutory definition or narrow the scope of a statute. So I don't think we would have, and I think that applies to the first section of CVS's comment as well. The second section of CVS's comment, I think, is a little different, but we can't modify that statutory definition or scope.
So I guess along those lines, just for clarification. So when we look at, the things for the 90th legislative session, is that something that could be looked at? I guess it wouldn't be from us, though. It would be from others. Okay. Any other comments, questions?
did want to kind of modify my request to make it simpler, I guess, and possibly less close to substantive. What if on line 54, pharmacist who provides telehealth service shall assure or ensure, or whatever the appropriate term there would be, that informed consent. So they would confirm that there is an informed consent on file, or that it has been obtained, and if that hadn't been obtained, they would obtain it themselves before delivering the service. I think obtain, maybe assure.
Sorry, I'm just checking the statute real quick.
No problem. Thanks.
So you want to say shall ensure instead of shall obtain?
Sorry, I wasn't on mic. Yes.
Okay. So you don't want to have agent in there anymore. You want it to say ensure instead of obtain.
Correct. Yeah, because if it's already been obtained, that would just kind of simplify that language too, or the language change.
But wouldn't that have to then change line 63? Recording the initials or identification of the pharmacist who obtained the consent? Wouldn't that have ramifications there?
Yes, we'd have to change that as well to say a pharmacist who ensured the consent was obtained. Yes.
So I guess practically speaking, I'm thinking about how this would look like in a alternative practice, like a medical practice or a dental practice or something like that, right? So I don't know that you would have that double documentation, right? So they would assure the documentation is there, but do we need them to acknowledge that the documentation is there if they're also still required to produce the documentation? Does that make sense? Like, why would we also, they would need to document that verbal consent was obtained, and that would be recorded under their name. That might be electronic signature, but would we also need, so would we need, if there was written consent, would we need a pharmacist to put in their progress note then that they sign, confirm that consent was present, right? Like, I would almost say, I mean, you could leave it. I feel like it's just administrative burden for not really, I don't think it really adds anything necessarily.
So you're wanting no documentation that a pharmacist verified that informed consent was obtained?
Yeah, I'm just thinking about what the mechanism for that is. So, like, if we have a patient, so I'll just walk through the process, and I think that kind of helps illustrate why I think that might just be duplicative. So, if you have a patient, and let's say you're going to enroll them in a telehealth service, before they do that telehealth service, when they get scheduled, right? When they get scheduled, they get sent a consent, a whole host of consents, not just this, but also like, you know, if a medical emergency happens and like all the other things that are legally required for any type of visit like that. And they sign those consents before the visit. And so usually it's set up to where you can't actually even conduct the visit without the consent being there. Now, that isn't necessarily required, but that's kind of the way that looks. So they would do the visit, but you would still be able to track when that consent was signed. And so if, like, let's say someone didn't obtain the consent and we're trying to enforce a rule, right? You would be able to see, it would be timestamped. So you'd be able to see, you know, that they conducted a visit before obtaining informed consent. Now, if they're getting verbal consent, like let's say the paperwork isn't done and they call the patient for the scheduled encounter and it doesn't give them a hard stop, they would be required, by the way this rule is drafted, they would be required to get verbal consent. And so they would need to document that, and that would be documented. But it isn't normal in medical practices or pharmacy practices that engage in those types of activities to say, hey, and I double check that there's a written consent, if that makes sense. because it's a written consent. It's already documented. It's already dated. It's already like there's an official documentation there already. You're just checkboxing it essentially at that point.
But I think it'd be your responsibility to make sure it was there before you provided a service. And I think
Sure.
that's what the legislators are trying to get to.
Absolutely. Absolutely. But you don't need them to say, oh, and I checked that there was consent, because they're responsible at that point. If there isn't a consent sign, that they would be in violation of the rule already without documenting whether or not they did it.
So Randy, in that situation, is it that particular pharmacy is owned by that medical entity so they can access those records? But what if it's not a pharmacy that's part of that entity?
Yeah. So what I'm actually talking about is not necessarily a pharmacy. It's actually pharmacists, right? So like you have scenarios where you have collaborative practice that can be engaged in a hospital, academic medical center, FQHC, et cetera. They engage in these types of activities, right? And so they do have that health record connection with the consent. But in the same scenario, it'd probably still be the same, because like if I'm like, let's say I set up an independent pharmacy and stood up shop, and which I'm not going to do, by the way, let's make that really clear on the record. Let's say I set up an independent pharmacy that's going to deliver telehealth services, right? And it's going to engage in maybe adherence calls and things like that. I would still be required to obtain a written or verbal consent from them. So if it's a written consent, it's already documented. That's kind of my point. A written consent is already documented. We just have to retain that record, right? But the verbal consent is where you would actually need to document, where we would want the pharmacist to document and say, obtain verbal consent from patient for data processing, or sorry, for treatment, data collection, and data sharing. Like they would actually need to document that statement. That's typically how verbal consents work, is you have to document them that way. So I think, my recommendation, just because of the fact that a written consent is already written documentation that you retain, right? And it doesn't necessarily, it's signed by the patient, not by the pharmacist, right? They're the ones consenting. I would actually say, like, maybe modify to that, that if obtained verbally, the informed consent shall be documented by recording the initials or identification code. Because there's not another scenario where it just doesn't make sense to do it, I guess. It just seems extra.
I think we're making all of this extra and we're overcomplicating it. Every day we get consent from people to counsel, talk to them on the phone, all that kind of stuff. It's an implied consent. When it says here, a pharmacist will get, you're not going to start talking to somebody if they don't want to talk to you. So I feel like we're just overcomplicating this, and it's an administrative thing. That it's fine as written. That's just my opinion.
So just for clarity, so the counseling, calling into the pharmacy, having a discussion with a patient, is that inclusive in that telehealth service? Or it is? So all of
Most
that?
likely. And I think the way that this rule wasn't written for there to be a second redundancy signature, because the rule was written under the assumption that the pharmacist was the one obtaining the consent, right? So the rule was written assuming that you're going to be documenting the pharmacist who obtained the consent. So it wasn't, I think the redundancy is happening with the shift that we're trying to make with it. The original outline was just you have to document the consent and that you're the person who got it.
Would it work for what Randy's asking for if it said obtain or verify?
I think that gets complicated too.
Mm-hmm.
I think if we're going to have this as a verification, it's going to be a pretty substantial amendment, and we're going to have to look at how to do that, because then again, it's written under the assumption that we're documenting who obtained the informed consent. So if we're now documenting a pharmacist who verified it, then we'll go back to who obtained the informed consent. I think when we were talking about pharmacist or agent, that was pretty straightforward. But getting to this, the verification or ensuring, I think it's getting a little more complicated.
Yeah, the problem is that it's not, in many cases, it's not an individual that is obtaining the consent. They are confirming consent because it's just a blast that comes out from the health record. We've gotten them. I'm sure you've gotten them before. They just blast out it's set up that for this type of visit, these types of consents get sent. Now it's the provider's responsibility that before they start that visit in all settings, regardless of telehealth or anything else, there's consents involved. There's whoever's providing that care has to verify that consent is there, but they're responsible for verifying that. But they're not in other settings of consents. They're not. No one is responsible for documenting that a written consent is present, if that makes sense. And that's the reason I'm kind of.
But it doesn't have to be written. It can be verbal.
Mhm.
It does not have to be written. It can be a verbal consent. This is just saying it's that you have either one. And if you look at the actual bill, it says it's related to patient's consent to treatment, data collection, and data sharing. To me, as far as like when you're counseling somebody, that's not treatment. That's counseling. So that falls to me under something different. I don't know if you see it that way, Megan, but I guess my question would be, what is an inspector going to come and look at and say, do you do telehealth services? Yes. Okay, show me your consents, show me your records or
Records.
whatever. But if you went into any pharmacy, independent, retail, whatever, and you asked, do you do telehealth? They're going to say no unless they specifically sit down, make appointments, and talk to somebody. To them, I don't think counseling or talking on the phone or anything like that would be considered telehealth.
Mhm.
Is that how you would think the auditor or any inspector would see it?
I think we could give guidance to the inspectors as to what we want them to look at. I don't think we can.
You're
I have it on. Is it not?
Can barely hear
not
you.
close enough.
Sorry. I think we can give guidance to inspectors as to what we want them to look at. Again, we can't narrow the scope of anything that the legislature did, but we choose what the inspectors look at, and we choose what enforcement discretion we take.
I guess to address my previous concern, I would recommend maybe shortening 62, 63. Informed consent shall be documented as follows. Because again, it's like I'm thinking about all the things that are already like a written consent is already a record, and it doesn't necessarily default to have anyone's initials on it except for the patient's signature, right? So why would we document a written thing? So I would just recommend that informed
think-
consent shall be documented as follows.
I think the reason that we're trying to document it is because the statute itself, the bill that came out, requires us to adopt rules that address the specific consent documentation.
And that's okay, but there's nothing in there that says there has to be initials. Like that's kind of my point, is like it's in there already. And if it's not in there and they do a telehealth encounter, then they violated the rule. So what is the goal of having initials present?
It makes it a lot easier to show that that's the pharmacist who did it and got it. That's
But the pharmacist isn't doing it, is kind of my point. The pharmacist is assuring it's present.
Mhm.
So it's kind of like it's like anything else we check. We don't document every single step of a process. That's the reason I'm kind of pushing back on it, is it seems completely unnecessary. Because if it's written documentation, it's already been signed and dated by the patient. If that date falls after, then the pharmacy is responsible. If the consented and present, you're going to go to the treating pharmacist, right? Like who delivered the service, and they would have documented that in some way, right? So you already know who didn't do it.
Mhm.
So the initials just tells you who did do it. That just doesn't. It just
I'm
doesn't
just
make
trying
sense.
to tell you why we drafted it the way we did. I'm
Yeah.
not trying to argue with you about it.
Sure. No,
If you want us to change it, we're happy to go back and change it.
yeah, that would be my recommendation. I recommend
So
change.
what you're saying is the pharmacist is not doing it. It's the agency or the establishment that is managing the telehealth process. Is that what you're trying to say?
there's
essentially?
there's a whole
Because if
host
you
of
read the
people that
language,
could
it
be.
says the agency managing these things will do all this stuff. So, I mean, that could be anything though.
Yeah, it could be a medical assistant in the practice. It could be a pharmacy technician if they have pharmacy technicians working in their space. It could be, like I said earlier, it could just be an electronic blast that the patient signs.
Your microphone, Suzette.
Does it say a pharmacist needs to do this? We just added that, right?
Correct.
Okay, yeah. No, I'm talking about the the bill.
Correct. It doesn't mention the word
It doesn't mention
pharmacist
a
or
pharmacist. I
physician
think that's what
or
Randy's
anything
trying to
like
say,
that.
right?
And
Okay, and so not to complicate it, but just listening to both sides and trying to discern this. So what if it said the informed consent shall be documented by recording the initials or identification code of the pharmacist or agent who obtained or verified the consent as follows? Because whoever's going to start the service is going to verify that consent release has occurred. So it could be any individual at that, or the agent at that point.
it seems silly. It really, I'm sure what I'm saying sounds silly, but if you take this in the context of it, we're not adding value by having their initials present. Because if I'd suggest one of two things. So either one, because a written consent's already written documentation. That's kind of my point, is like, why do we need to document that someone verified that it was present when the rule is that it has to be present? Right? Like it's, you will know when the rule is violated by inherently. So there's no value in adding an extra set of initials or an extra signature or something like that. And the only reason I'm kind of pushed back on this is that consent systems aren't built this way. Like if you're utilizing a consent system that's in an electronic health record, they're not built to have an extra step where you acknowledge that a consent is present, because the consent's either present or it's not, right? Now for a verbal consent, I actually think that's very appropriate. Like we need to know who obtained verbal consent and what they consented to, right? If you're doing the type of service that I described, not what Donna was describing. But if you're actually delivering some type of treatment, like if you're functioning like in a collaborative practice or something like that, you're delivering it via telehealth, then yeah, you absolutely should document in the record patient verbally consented to treatment, data collection, and data sharing. It's like documenting that, hey, and there's a prescription record present. I'm required to keep a prescription record. Why do I also need to document that I assured that the prescription record is present, right? Same, that's kind of the analogy I would give in kind of more of an operations standpoint. You're documenting that documentation is present. That dog don't hunt. But if you're obtaining verbal consent, you should have a signature or acknowledgement.
Just to go back to the statute, if you'll look at section 111.002, it states a treating physician, dentist, or health professional who provides or facilitates the use of telemedicine, teledentistry, or telehealth services shall ensure that the informed consent of the patient or other appropriate individual making decisions on behalf of the patient is obtained before the telemedicine, teledentistry, or telehealth services are provided. So I think the issue here arises from, this scenario of like a collaborative practice agreement where you have two different health professionals. You have them, maybe physician on one side, pharmacist on the other side. But because they're providing consent based on two different standards, or obtaining consent using two different standards of care, I'm not sure that we can rely on the consent that was obtained by the physician in order to satisfy our statutory obligation to obtain the consent for whatever telehealth service the pharmacist is providing. That's my 2 cents.
No, so that's actually a fair concern. So what we've seen, because this, to y'all's point, this has been in statute already, right? So a lot of organizations that already knew about this have already made adjustments to what they're doing, right? So for example, the telehealth consent that we utilize within our own health system, it actually states all the different types of services. So they're consenting to telehealth pharmacy services, telemedicine services, and those types of things when they do that initial consent.
Julie, wouldn't this be addressed by Randy's initial suggestion that says 954 shall ensure the informed consent is there instead of obtain? I mean, that might just ensuring that it's there, whether it's obtained verbally or written or what have you.
I think that's a must change, but
It's
the
a must change.
6263, it's just extra. It's just documentation to document. There's no, I don't see a value
But
in
didn't you
leaving.
want in 6263 for that to apply to the verbal informed consent?
Yes, absolutely. And I think it should.
Okay, so we're really not trying to get rid of 6263. We're just trying to limit it to a verbal informed consent.
That would be wonderful. Yes. Now, the trick is you still need the consent. The only reason I was going to suggest modification of it is because in a different way or a limiting part of it, part of the language there is because you still want the consent documented. So that's kind of the challenge. So I think, yeah. So if it's a written consent, you need that retained, right? So they have to keep that record. If it's a verbal consent, then yeah, you would document it in that record. So that's the reason I was kind of suggesting informed consent shall be documented as follows. So strike that middle portion. And then you could put something at the end that initials or identification code of person or electronic signature or whatever of person for verbal consents, electronic signature or whatever. So that would be a D, I guess. So that way you're still saying you have to keep a record of the consent, but you only need the identification code of the person obtaining the consent if it was verbal. If that makes sense, is what I would propose.
Can you not put in there the informed or the informed verbal consent shall be documented by recording the initials or identification code of the pharmacist who obtained it? Can you just add the verbal?
Actually, you could. I think I was making it more complicated. Sorry, because I didn't see number 3 there. So number 3 says that you have to keep documentation of informed consent. So that would apply to all consents, including written, right? But then 2 would just be specifically about verbal consent. Verbal informed consent shall include documentation. I think that would be.
Make it would that be able to be added, that word verbal in front of that informed?
Yes, we can add that. I do think this is going to be substantive and it's going to have to go back out for comments, but yes, we can do
Okay.
that.
I'm sorry about that, but I didn't catch it the first time. I was digesting the first time.
But to Donnie's point, I don't think that. I mean, you're still going to have to identify how your electronic record is kept to some degree.
Well, you'd leave that like it is on 4, 5, 66, and 67. Is that what you're asking?
Well, if 62 is just verbal consent, I mean, it does say that, in your case where it is electronic, I mean, I guess it's implied that it's in the data processing system.
Yeah, I think I'd asked that last time. That data processing system could be in lieu of electronic health record.
So, Megan and Iman, does that give you enough information to do a rewrite and bring this back as proposed?
Yes, I think so.
All right.
So it would be brought back as for potential adoption.
For
So we'll
potential adoption. Okay.
Send it back out as a proposal, assuming y'all vote to do this, and then bring it back for potential adoption next time.
All right. So do we need a motion then to take it back to proposed or
Well, I think you all need to agree that you want to make these changes.
these changes?
I make a motion that we're going to send it back for changes that we need to make.
For the discussed changes.
Yeah, discuss changes.
Do we have a second on that? Yes, we have a second from Jenny. All those in favor? Motion carries. All right. John, you want to take us to the proposed rules?
Yes, Madam President. The first item on your agenda is C 2.1, amendments to 283.7 concerning examination requirements. You asked us to bring forward this rule after it was a discussion item at the last board meeting in February. And this would simply allow pharmacy students to take the MPJE after their third year of pharmacy school. So when we look at the rule itself here, we look at line 8, provides an exception that says, except as provided in paragraph 3 of this subsection. And then when you go down to paragraph 3 on lines 23 through 36, it provides an applicant who has completed the 3 didactic years of pharmacy education, i.e. P1 through P3 years, may take the Texas Pharmacy Jurisprudence examination a maximum of 1 time prior to graduation from a college/school of pharmacy. It also removes some out-of-date information. And that's really the change.
All right. Board members, we do have Diane Ginsburg that would like to speak on this before we just deliberate or discuss. Diane?
Got to get it for short people. Good morning, everybody, and thank you for your time this morning. For those of you I don't know, my name is Diane Ginsburg, and I'm here representing myself as a pharmacist. And I appear before you this morning in support of those proposed amendments to 283.7 regarding examination requirements, which, as stated, would permit PharmD students to sit for the Texas Multi-State Pharmacy Jurisprudence exam prior to graduation under conditions that are established by the Board of Pharmacy. This change is consistent with the board's statutory authority, preserves all public protection safeguards, and aligns Texas examination requirements with the educational sequencing and successful pilot experiences in other jurisdictions. The proposed amendments appropriately distinguish eligibility from licensure issuance. The language is both narrowly tailored and regulatory sound. It clearly preserves the board's discretion to approve or deny examination eligibility, verification of educational completion prior to testing, and the statutory requirement that no license is issued prior to graduation. As reflected in the amended language, MPJE eligibility is linked to completion of pharmacy law coursework, not degree conferral. And this distinction reflects how PharmD curricula are structured. Pharmacy law courses are typically completed before students begin their advanced pharmacy practice experiences. Jurisprudential competency is achieved during their didactic phase of the curriculum, and graduation status does not enhance or alter knowledge of pharmacy law. By aligning this section with educational sequencing, the board ensures that MPJE assesses candidates at the point of maximum curricular relevance while maintaining licensure standards. Pilot experiences in the states of North Dakota and Wisconsin reinforce the appropriateness of this amended language. Key safeguards that are mirrored in the Texas amendments include completion of pharmacy law coursework prior to eligibility, board verification before authorization to test, and explicit prohibition on licensure issuance prior to graduation. The outcomes from the pilots demonstrated that there was no compromise of public protection, no erosion of examination integrity, and comparable or improved MPJE pass rates in at least one of the jurisdictions, and that there was reduced time between graduation and licensure without regulatory risk. A concern that's been previously raised during the pilot evaluations was that taking the MPJE earlier in the educational sequence might reduce pass rates in some cohorts. And then the structured language in the amended language directly mitigates this risk by limiting eligibility to those who have completed didactic education, preserving a single attempt structure when used in the pilot models, retaining full board discretion over approval to test, and maintaining graduation as a non-negotiable prerequisite to licensure. I believe these guardrails ensure that the amendment modernizes timing without lowering standards. Believe the proposed amendment does not permit early licensure, does not waive internship, graduation, or application requirements, and does not diminish the board's authority. Instead, it improves efficiency while preserving statutory compliance and patient safety. The explicit language in these proposed amendments reflects careful regulatory drafting that balances flexibility with accountability. by allowing eligible PharmD students to sit for their MPJE prior to graduation while clearly prohibiting licensure prior to graduation, the board modernizes examination scheduling without compromising public protection. And for these reasons, I would strongly support moving forward with the adoption of proposed amendments to this section. And I'd be happy to answer any questions. Thank you for your opportunity to speak.
Thank you, Diane. Are there any questions for Diane?
Drew, I had a quick question.
Good morning.
Good morning. The pilot states, you said North Dakota and Wisconsin.
Yes, sir.
Was there an impact to the passage of the NAPLEX along that? Were the students able to focus on that?
I don't have that data. I don't, when talking with NABP about this, because it was separated, you would think and hope that NAPLEX pass rates would go up by separating the two exams, but I don't have that data to speak to that.
And the last question, in those states, do you notice the students obtaining their licenses quicker?
I can't speak to that. One would hope that they would by having one of their examinations done. Part of it would depend on whether those students stayed in that respective state to get licensed, which you would think if they took their state MPJE, but I don't have that data. I'm sure NABP does.
All right. Any other questions? All right. Board members, what comments, questions?
Julie, we don't have any comments from the schools or anything like that, do we? The schools didn't have any opinion on it?
Nobody had requested to come in prior to, but this discussion item came from, district meetings where all of the schools were asking about it and really trying to get this to be something that would occur. But we don't have any comments for today. Yes, Diane?
Obviously, I'm not speaking officially on behalf of my college or any other, but this was brought up at the Texas Pharmacy Congress meeting, presented to all the CEO deans and to the whole Congress as a whole back in November. And there was support from all of the colleges and schools related to allowing for the MPJE to be administered, for students to be able to take it early.
Thanks, Diane. Any other? Do we have a motion on this?
Julie, I think this is a very forward-looking rule and has great advantages to it, so I'd like to propose that we adopt.
We have a motion from Rick Fernandez, a second from Jenny. All those in favor?
Aye.
Any opposed? Motion carries. John?
All right, Madam President, we're going to go, the next two we're going to do together, and we're C 2.2, amendments concerning disasters and notifications. And what we're looking at here is to prevent misinterpretation of what qualifies as a disaster and requires the pharmacy to notify the board of ceasing to operate. And the first one we're going to look at here is C 2.2.1, amendments to 291.3. This is the required notifications. And if we scroll down a little bit to lines 90 through 93, you'll see the changes here. It provides that the fire, flood, or natural disaster, it provides that if a pharmacy experiences a fire, flood, or natural disaster that may have affected the strength, purity, or labeling of drugs, medications, devices, or other materials used in the diagnosis or treatment of injury, illness, and disease, the following requirements are applicable. And we go down just a little bit to line 95 through 99, talking about the responsibilities of the pharmacist in charge. It provides that the pharmacist in charge shall be responsible for reporting the date of the fire, flood, or natural disaster to the board within 10 days from the date of the fire, flood, or natural disaster. And if we scroll down to lines 122 through 125, here it provides that if the pharmacy closes due to a fire, flood, or natural disaster, and timely notifies the board under subparagraph A of this paragraph, the pharmacy may be closed for not longer than 90 days. And then when we get all the way down to lines 234 through 239, we're going to talk about loss of data. And this was caught by board staff as something that was required but was not part of the required notifications. And so it provides that as provided by rule sections 291.3 34E, 291.55A, 291.75C, 291.104A, and 291.105E of this title relating to records, operational standards, and pharmacies located in a freestanding emergency medical care facility or Class F. When a Class A, Class B, Class C, Class E, or Class F pharmacy experiences a significant loss of information from its data processing system, the pharmacist in charge shall report the loss to the board in writing within 10 days of discovery of the loss. The next one we're going to look at in conjunction with this is amendments to 291.11. This is C 2.2.2, 291.11, operation of a pharmacy. And you'll see here the changes, lines 11 through 15. It provides that cease to engage in the business described in the application for a license means the holder of a pharmacy license, once it has been in operation, discontinues operating the pharmacy for a period of 30 days or longer. Here's the new part. Except as provided in paragraph 3 of this subsection. So let's look at paragraph 3, lines 16 through 20. A pharmacy may discontinue operating for not longer than 90 days if the pharmacy experiences a fire, flood, or natural disaster that may have affected the strength, purity, or labeling of drugs, medications, devices, or other materials used in the diagnosis or treatment of injury, illness, and disease, and timely notifies the board under 291.3G, which we just looked at, of this title relating to required notifications. And those are the two together, Madam President.
Thank you, John. What is the pleasure of the board on this?
So after 90 days, you have to obtain a new license and start over, basically. You must notify the board in 10 days when you're closed up. Okay.
It better defines what was existing.
Will there be forms readily available online?
The forms already exist.
It
So
is,
the 90
okay.
days already exists. What we're trying to do is clarify what counts as a disaster. Because the way that it's written now with other disaster, people have started interpreting that very liberally. So we've been told that a loss of clientele is a disaster and they should be able to close for 90 days. Their computer glitching is a disaster and they should be able to close for 90 days. And so we're trying to really bring it back to, no, this is supposed to be about something that affects the drugs. It needs to be something, outside of their.
It clarified the existing intent.
Mm-hmm.
Hey, Rick, I have a question for you. When we had those hurricanes that affected your stores and this occurred, do you just move the business from one location to another one? How does that actually work in your?
That's an option you would do. Yeah, move it to another location, the medication as well, records and stuff, and then notify the board of that until you can rebuild or do something.
Yeah, in some cases, we've brought trailers in and put a temporary pharmacy in the parking lot to remain open and taking care of the public.
Okay. Thank you.
So do we have a motion to propose on this? I have a motion to propose from Donnie and a second from Randy. All those in favor? Any opposed? Motion carries. John, you want to take us through C.2.3?
Yes, Madam President. This is amendments to 291.55 concerning records. And what all we're doing here is bringing the records requirements for Class Bs in line with the other classes of pharmacies. And so if you look at lines 32 through 34, once again, we're talking about loss of data. The pharmacist in charge shall report to the board in writing any significant loss of information from the pharmacy's data processing system within 10 days of discovery of the loss. And again, this is just making sure that all classes of pharmacy need to do this.
All right. Board members, do we have any comments or do we have a motion? I have a motion from Donna. Do you have a second? Second from Randy. All those in favor? Motion carries. All right, John, if you want to take us through rule review.
Yes. Board members, the rule review and approval plan for fiscal year 2026 to 2029 is the tab that you have in front of you. And again, I'll remind you that the purpose here is to see if you still need these rules. It is not about the content of them, and the legislature requires that we review the rules on a 4-year cycle. So, C 3.1 for proposal today, we have C.3.1.1, Chapter 281 concerning administrative practices and procedures, and C 3.1.2, Chapter 311 concerning the Code of Conduct. And again, those are for proposal today.
All right, board members, do we have a motion to propose on this? Have a motion from Randy and a second from Suzette. All those in favor? Any opposed? All right, John, motion carries. All right. Danny, do you want to take us through D?
Yes, ma'am. So D.1, the Prescription Monitoring Program Advisory Committee, they did meet on February 27th. Ideas were discussed. No decisions were made at that point. Next meeting is still pending. Lily's reached out to Dr. Engel, maybe sometime in June for the next meeting. D.2, the Interagency Prescription Monitoring Program Work Group did not meet. There was not a reason for that group to meet. That's it.
All right, thank you, sir. All right, board members, that takes us to E on our agenda, which is our financial update. Ruben, do you want to take us through our finances?
Yes, Madam President. Good morning. Good morning, ladies and gentlemen of the board. As a financial resource representative for the agency, I will be going over the first 3 agenda items within E.1 regarding the agency's financial updates. I want to start with the financial documents provided to you, starting with E.1.1, which is the agency's review of fiscal year 2026 second quarter expenditures. This budget status report reflects the agency's cumulative expense activity from September 1st through February 28th. The next item on the agenda is E.1.2. This report is the review of board member travel budget. The spreadsheet details and reflects the board's in-state and out-of-state cumulative travel expenses as of the end of the second quarter of fiscal year 2026. And lastly is agenda item E.1.3. For the second quarter of fiscal year 2026, there wasn't any consideration of material changes to contracts for goods and services for board review. At this time, I'm available for any questions you may have regarding the reports you have received and reviewed. Thank you, members.
Thank you, Ruben. Thanks for all you do for us. Any questions for Ruben? All right. Thank you again, Ruben. All right, Danny, will you take us through the review of LAR?
Yes, ma'am. So E.1.4, behind that is the legislative appropriations request for FY 28 and 29. This is for review and approval. Notice this includes the exceptional items and the fee projections. Fee projections are just informational only. The approval is only for the exceptional items. Executive committee met last Thursday, and they approved this list here. We're here, and me and Megan, we're here for any questions that you guys might have.
All right, board members, do you have any questions on the 28-29 LAR? If not, we're going to need a motion to approve the exception items only. Donna has made a motion to approve the exception items. Do we have a second? Randy has made a second. All those in favor? Any opposed? Motion carries. All right, board members, next on our agenda is our PRN. So I'll ask Raquel to come forward. I saw her come in. And then Caroline, do you want to start us off?
Yes. So we're looking at E.2.1, and this is board staff's chart that you're familiar with. The first part is historical. The top chart's historical data on the number of participants in the peer assistance program. The bottom chart is the current fiscal year. We started off last quarter with the count of the number of participants at the start of the fiscal year that were in the program. And you're looking at the second quarter data for those participants that were added during the second quarter. So again, it's a cumulative count where we're adding from the start of the year each quarter the participants. And those are categorized by their license type.
Any questions for Caroline? All right, Raquel, the floor is yours.
Thank you. Good morning, Madam President, members of the board and staff. My name is Raquel Leal, and I'm the director for PRN. I'm here this morning to read PRN's report for the past quarter. The Professional Recovery Network continues to receive a number of referrals regarding potentially impaired pharmacists and pharmacy students. Compliance by current participants is acceptable, and all concerns regarding public safety have been reported to TSBP. On January 22nd, PRN presented to the first through third year student pharmacists at the University of North Texas's UNT Health College of Pharmacy. Mental health and substance use statistics about healthcare professionals were discussed, as well as the importance of mental wellness in the pharmacy profession. On February 13th, PRN staff spoke to the students at the University of Houston College of Pharmacy. The presentation, part of the college's Drugs, Alcohol, and You seminar, included topics such as how addiction stigma creates barriers to recovery and the increased addiction risk factors for healthcare professionals. On March 2nd and 3rd, PRN participated as both an exhibitor and an attendee at the Texas Substance Use Symposium in San Antonio. Texas SUS is an annual conference dedicated to reducing the impact of substance use across Texas, bringing together hundreds of professionals from healthcare, behavioral health, recovery, and public safety sectors. The symposium provides attendees with practical tools and knowledge to address local challenges and drive meaningful change. Also in March, PRN attended the National Organization of Alternative Programs conference in Houston. The topic of the conference was empowering professionals to embrace best practices in monitoring amid ever-changing environments. NABP was established to promote public safety through participation of healthcare professionals in monitored rehabilitation and recovery as an alternative to licensed discipline, emphasizing fitness to practice and retention of competent professionals. PRN looks forward to continuing to work with pharmacy schools and other opportunities across Texas to bring awareness to the program. LBB numbers for this past quarter were initially submitted to TSBP on March 10th. LBB numbers include all licensed pharmacists and pharmacy students enrolled in the program. We have, as of the past quarter, we had 0 volunteer pharmacy students, 1 board-ordered pharmacy student, 17 volunteer pharmacists, and 34 board-ordered pharmacists. And the last page of the report, you'll find our financials. And that concludes my report.
Any questions for Raquel? Raquel, thanks for all you do, and especially going out with that outreach to the pharmacy students. I think it's so valuable.
Of course.
So thank you. All right. With that, we're going to skip down to E4. And Danny, do you want to take us through the strategic plan?
Yes, ma'am. So E.4 is the strategic plan and customer service surveys for FY 27 through 31. Again, looking for review and approval of this document. And we're here for any questions if you have any.
Board members, I know that you've reviewed this. Are there any questions? We will need a motion to approve. Got a motion to approve from Haisha and a second from Rick Tisch. All those in favor? Any opposed? All right.
Thank you, guys.
Strat plan is approved. All right. Next on the agenda is just looking at the calendar of events. Board members, you can see on the E.5 list of the holidays of the office will be closed, as well as some skeleton holidays. And this is out there for us to have and for the staff to be able to follow. Any questions on the holidays or the calendar? All right. With that, we'll kind of look at the resolutions for NABP. So if you'll open up E.6. These resolutions were submitted to NABP. There are a number of us that are attending the conference next week. And this is really just to get a feel for how you feel about these resolutions. So as Rick and I and Donna are there, we convey your thoughts as votes come up. So District 2 has one. It's also co-supported by District 1. And it has to do with lyophilization and compounding. And this is a resolution that is resolving that NABP work with the FDA and USP to clarify federal prohibitions for compounding essential copies of drugs, under what circumstances, if any, a pharmacist may perform lyophilization, and amend the model law and regulations as necessary. Thoughts? Jenny, I'll look to you. Any thoughts on? It seems pretty easy and okay. Any other thoughts on that? All right. They also had a resolution that NABP create model language that pharmacists should be authorized to prescribe, order, and administer all vaccines, and should be permitted to delegate administration of all vaccines to pharmacy technicians and pharmacy interns under the supervision of a pharmacist, encourage states to adopt standard of care and evidence-based approaches that empower pharmacists' clinical judgment, and define eligible vaccines as any vaccine. Thoughts? Questions? No issues with this? All right. There was also a blueprint resolution that resolved that NABP convene a work group to review the Uniform Blueprint Inspection Report to ensure it fully complies with USP standards and be completed by state inspectors within a reasonable amount of time, and ensure that participating blueprint states are fully inspecting for compliance with USP compounding standards. Any objections here? I see a shaking of the head no. You're on the next one? Okay. Any issues here? None. All right. Their next dealt with virtual facilities. And it was, therefore, be it resolved that NABP convene a work group to recommend amendments to the model law and regulations to create a virtual specific license for manufacturers and wholesale distributors, develop specific requirements that are appropriate for a facility that does not physically possess drug, or consider whether the designated representative should be licensed. So this would be forming a work group or task force if it was passed and accepted.
I feel dumb for asking, but I'll be the one to ask it. A what? What? How's? Does anybody know how this exists? Like, is this a? How do you manufacture drugs virtually? I guess. Does somebody know what this means?
I was going to ask the same thing.
So, I'll read the whole virtual facilities. It says, whereas virtual manufacturers and virtual wholesale distributors are becoming more prevalent, and whereas only 11 states have virtual specific license categories, 7 states have a virtual friendly application for a manufacturer or a wholesaler's license. 8 states have manufacturer or wholesaler applications that does not consider their differences, and 14 states consider virtuals exempt. Whereas the NABP model laws do not distinguish between the standards for a virtual facility compared to a traditional facility that physically possesses drugs, and whereas a designated representative is not required to be licensed but doesn't assume responsibility for ensuring compliance and mitigating risk with diversion and counterfeit activities, therefore be it resolved, and that's where the resolved comes in. I'm not sure that answers our question totally. And it could be that we don't make any ruling or any indication on this, and this is something that Rick and Donna and I research while we're there.
So a question on the states that it lists, like is Texas in any of those states? Do we know?
We don't have any rules about virtual facilities.
So I think it's basically where a company owns the patent to the product, but outsources all the physical everything.
I believe so.
Yeah.
So you guys can kind of discuss that as you're at NABP.
We'll take that as an action item then. Are we in agreement with that? All right. District 6 has a resolution on community health workers. And their resolution is that NABP encourage board members review applicable law regulations to remove unnecessary barriers to authorized pharmacy technician CHW activities, provided such activities are appropriately supervised to ensure activities are safely and properly performed. Any issues? Y'all are being very quiet, but you're shaking your heads that you're okay. All right. And then from the Missouri Board of Pharmacy, one for medication safety for high alert medications. Theirs is, therefore, be it resolved that NABP convene a comprehensive group of industry stakeholders, i.e., pharmacy electronic data processing system vendors, PBMs, commercial insurance, and government payers for healthcare coverage and medication safety organizations, data standard organizations, and providers of clinical and descriptive drug knowledge that is integrated into healthcare systems to create a standardized, actionable clinical drug alerts to be implemented in pharmacy electronic data processing systems to eliminate unattended medication events experienced by patients in the dispensing of high alert medications. So this would be basically coming up with another task force.
The only thing I'd maybe say, see if they want to squeeze in there is, and it sounds like it's the same, but it's not, but PSOs, so patient safety organizations, so like Press Ganey and things like that, they do collectives and know trends. And
Yeah, well,
so
we can't modify the resolutions. This is going to be whether
gotcha.
or not at NABP it's accepted or whether or not it's voted down.
Got it. Okay.
So, but
yep, I'm with you. Thanks.
Any issues here? No. All right. I will remind everyone that the deadline for volunteering for NABP task force is coming. So make sure you look at your NABP communications and sign up accordingly. All right. Moving down on our agenda, Mr. Merriman, do you want to take us through P, please?
Good morning, Madam President and members of the board. First, I'd like to give a quick report on program or feature updates to the PMP. The PMP team continues our efforts to convert to a new administrative license verification tool. As part of this conversion process, we are deactivating accounts that we have determined are no longer in use by the account holder. Also in January, we enabled a clearinghouse setting which prohibits pharmacies from reporting zero or negative quantity dispensations. Next, I'd like to highlight some of the PMP statistics compiled from PMP data reported during the second quarter of fiscal year 2026. These stats are summarized on the summary stat sheet found behind tab E.7 on the agenda. There were a total of 2,962 new accounts that were granted to qualifying users during this period. By the end of the quarter, there were a total of 189,038 registered healthcare PMP users, which represents 70.1% of the total number of Texas licensed healthcare professionals that are eligible to have a PMP account. The percentage of eligible pharmacists that are registered with a PMP account decreased from 86.3% to 61.9%. I would like to note that the sharp decrease in pharmacist accounts can be directly attributed to deactivations I mentioned a moment ago. The percentage of eligible physicians that are registered with a PMP account increased from 91.2% to 92.6%. Regarding searches to the PMP, there were a total of 84 million searches during this quarter. Of that number, 43.3% of all searches were conducted by pharmacists, while physicians conducted 42.4% of the total. Additionally, out of the total 84 million searches conducted, 67.8 million were integrated electronic health record searches rather than manual PMP searches. And finally, the graphic at the bottom right of the stat sheet illustrates the states or entities that Texas shares PMP data with as of the end of the quarter. I would like to highlight that in February of this year, we added one more state in which we have a data sharing agreement with, and that's the state of Vermont, which now brings our total to 42.
All right. Any questions for David? Rick?
A quick question. Do we have any reporting on downtime with PMP? Have we had any downtime with?
We haven't had. We do get a monthly report from the vendor. I know for April it was reported as 0, and it seems as if the last several months it's been 0% downtime.
Yeah, I was asking somebody about it that I work with, and it didn't document well. And I said, "Why not?" It was down, so I didn't believe him.
There you go.
So I appreciate that.
All right. Any other questions for David? All right. Megan, do you want to take us through the SOA hearing cases?
Yes, thank you. So we have the same case that you've been hearing about for a while now. That's the Amayosi matter. The petitioner had an agreed board order that was entered back in February of 2017, and we subsequently received an order of non-disclosure relating to the underlying contact. An attorney from the Attorney General's office is still handling the case for us, and you may remember that the Attorney General's motion to transfer venue to Travis County was granted on January 8th. Nothing else has happened in that matter.
All right. Any questions for Megan? All right. We actually have something scheduled at 10:30, but I know that probably a break would be in order. So if we can go ahead and adjourn until 10:30, and then we'll pick up the agenda at that point. right, we will go ahead and call this meeting back to order. And at this time, I'll invite Richard Galindo to come forward. Mr. Galindo is going to take us through E.3, which is status report on the annual internal audit.
Good morning, Madam President, members of the board, Commissioner and staff. Thank you for having me here this morning. I'm just here to provide an internal audit status update, and we have presented the internal audit plan to the board back in November 4th of 2025. We are prepared to do the audit of the licensing pharmacist, and that will begin, field work is planned to begin next week on May 11th. We will also perform follow-up if needed of any items that remain open from prior years. Thank you. And then along with that, we'll prepare the annual internal audit report. And that's really our status report as of now.
All right. Board members, do you have any questions on the status report? All right. Thank you, Mr. Galindo. We look forward to hearing your results.
Thank you very much.
All right. Board members, with that, we'll drop back down to E.9. And Megan, you want to take us through our possible statutory changes for the 90th session of the Texas Legislature?
I know, 90th session.
Mm-hmm.
Okay, so these are possible statutory changes that are being put forth for consideration by staff. And the first one, you saw this recommendation prior to the last legislative session. This would reconcile the text of Section 565.003 of the Texas Pharmacy Act. Back in 2019, the legislature passed two different versions of subsection 1 under Section 565.003 relating to the Texas Controlled Substances Act. Staff recommends reconciling the statute to cite the sections of the Texas Controlled Substances Act which are administered by the board as opposed to those administered by the Texas Department of Public Safety. So that's our first one. The second one is another one that you saw prior to the last legislative session, and this would clarify in Section 565.003A3 of the Texas Pharmacy Act that a technician or tech trainee may be disciplined for fraud, deceit, or misrepresentation in practicing as a tech or tech trainee. As you can see, similar language is included in the sections pertaining to pharmacists, but is not included in the section pertaining to techs, and staff recommends adding the language to the technician section as well. Number 3 is another one that you saw prior to the last legislative session, and this would clarify Section 562.0541 of the Occupations Code in relation to emergency refills of insulin. Because of concerns that the smallest available package might be more than a 30-day supply, and the pharmacist would have to break that package apart, staff recommends amending the language to remove the lesser of. Number 4 is a new recommendation. This would clarify in Section 481.076A4 of the Texas Controlled Substances Act that access to the PMP for death inquests or investigations is allowed for all positions authorized under the Texas Code of Criminal Procedure, Article 49, to perform death inquests or investigations. The current statutory language only lists medical examiners. However, in many Texas counties, there is not a medical examiner, and inquests into deaths are conducted by the Justice of the Peace or a death investigator acting under the supervision of the Justice of the Peace. In counties that do have a medical examiner, death investigations are often performed by deputy examiners. To ensure access for all death inquests and investigations, board staff recommends amending this section to list these additional roles. And then lastly, for consideration is number 5, and you have seen this recommendation before as well. It would align the qualifications of the executive director with those of similarly situated agencies. And while we hope that Danny stays with us for a very long time,
very,
at some point he may actually want to retire. And the Medical Practice Act, the Nursing Practice Act, and the Dental Practice Act do not contain the requirement for their executive director to be a physician, nurse, or dentist, respectively. So this qualification requirement would limit the potential future applicant pool for this position. And those are all of the suggested changes.
All right, board members, do you have any questions regarding these? All right.
So do we vote on these or just discuss
No,
them?
no,
Or
they're just out there. I mean, if we have comments, I mean, this is the time to bring that forward.
well, I would like to go on the record and disagree with number 5.
Okay.
Same.
Yeah, I mean, we don't do anything other. We can't lobby, so it's just out there. So we'll show that is the case. Okay. All right. Sean, would you take us through the 89th legislative session update?
Hello. Attached in E.10 is a chart of legislation that affects the agency and or the practice of pharmacy. Please note that this chart was presented during the February board meeting, and as such I will be only going over new information. Starting and ending with HB 1700, the bill establishes that each regulatory authority must create rules that standardize how health professionals document and retain patient consent related to various key aspects, namely treatment, data collection, and data sharing. Related rules were presented for potential adoption earlier in the board meeting and will be sent back out for comments on the proposed changes. That brings me to the end of the chart, and I'm happy to answer any questions.
Any questions for Sean? All right. All right. E.11 is a discussion point, and Haisha brought up that she would like to discuss notification for inability to fill.
Yes,
So-
thank you. I would like for us to consider a very narrow definition of when the rule would be imposed. My thinking is when a prescription is unable to be filled due to significant safety concerns or regulatory or other limitations, whether it is from ordering limits or dispensing limits of a pharmacy for a particular medication, where prescriber intervention is necessary for patient care. Right now, what happens is some pharmacies will tell the patient that the prescription isn't being filled. Some don't. I personally have had an instance where my son had pneumonia, and
Okay, let me stop for a second because this is all public, and so
that's okay. That's okay.
That would be
I'm
HIPAA,
good with
so I
that.
want to
I'm
make
good
sure
with
you're
that.
okay
Yep,
with
I'm
that.
good with
Okay.
that. I get it's recorded in perpetuity. Everyone
Yeah.
what happened to my son. I just want you guys to understand where I'm coming from. So thank you. And he had a prescription of antibiotics that wasn't filled and was actually canceled. And that bothers me that was okay to do. There are instances I know of where people need post-operative care, and due to pharmacy dispensing limitations, they're not able to get the medication. And because it's a controlled substance, it can't be transferred either. I wonder what it's like for someone who has just had surgery, or they've been in a car accident or something and they left the hospital or they've left the ER, and the pharmacy is telling them, sorry, we can't give you this medication that you need for care. And then the communication ends there. I don't know of an ER doctor in the world that would believe that a pharmacy wouldn't dispense medication. And how do you call your doctor at the ER and explain? So, and then we also, I believe, should look at how this impacts vulnerable populations, whether it's someone who is disabled, has a communication disorder, someone who is distressed because of what they're going through medically, elderly patients. I think that there's a population that would be well served by having the pharmacy communicate the inability or decision not to fill with the prescriber so that they can take appropriate action, and it closes the loop within the medical profession. I don't know of anywhere else in medical care where the onus is on the patient to relay critical medical information between those involved in their care. And yet for pharmacy, this is the case. So I would like for us to consider a very narrow definition of when it would be required. Perhaps it could have something to do with the critical nature of needing the medication, the time sensitivity, the reason the medication is needed, maybe, like post-op or acute care. I'm not proposing that prescribers be notified if someone chooses not to get it or it's an insurance reason, or it can be handled through patient counseling, things like that. But when prescriber intervention is necessary for patient care, I would like for us to consider closing that loop with communication between the pharmacy and prescribing physician.
And I think recently we did this to some degree. We have a joint letter with the medical board as far as, having an open communication and to communicate with the practitioner when we don't feel it's safe or we're not going to be able to fill it. And there's a change in the law, so transfers can occur on electronic prescriptions now. So that's made it that change is fairly recent.
So even for new controlled substance medications that aren't refills, they can be transferred? Okay.
Yeah, there's a new change in that which makes it a lot easier. There was a barrier to that prior.
Okay.
So that may help as well.
Yeah, it does. That alleviates some of my concern.
Mm-hmm. Thoughts, comments?
Well, in theory, I think what you're asking for is a standard of practice that we should be following. Pharmacists should be doing that.
Mm-hmm.
I get a little worried when we have notifications that are required. For what reasons? Obviously, we'd have to refine this suggestion here, because there's at least half a dozen reasons why you wouldn't fill a prescription. Then that would complicate the matter. You're talking about issues of professional judgment, possibly what you're saying. If the pharmacist doesn't feel comfortable filling it, they should tell the prescriber. That's what you're saying.
I think we need to be very narrow in where we draw the line. If it's something that, and I'll need y'all's help with appropriate terminology, and I'm going to use the word need, and I'm going to hate that that's recorded because I don't know that any prescription isn't ever actually needed, so forgive me. But I think that some prescriptions are more serious if not available in a timely manner, and they're maybe more needed critically. And so if prescriber intervention is necessary in getting the patient the care that they need, then I think there should be communication between the pharmacy and the prescriber, not the pharmacy, the patient, to the prescriber, to the pharmacy.
I think what you're kind of getting at is a lack of a bright line, the need for a bright line rule, but more of, re-emphasizing professional judgment. I mean, maybe what we're looking at is, instead of a rule, maybe education on the webpage. Better, we've got a statement now, but maybe it's more education, because that should be the expectation.
Right. And a lot of pharmacies and pharmacists do this, and I think that's wonderful. My concern is the ones that don't, and having them maybe elevate that care level to a baseline that many others are doing as a matter of practice.
So I think that in that case, just to what Rick said, they're not complying with the standard of practice. And that's what we see every month in our ICs and things like that. That would be a complaint that we would have investigated and figure out, did they do what a reasonable pharmacist would do? Because to his point, if this is a critical situation, that's inherent to us that we have to call, that we call doctors all day long kind of thing. Mm-hmm. If somebody's not, because they're being negligent or lazy or whatever, that's a problem. But I don't know that that's solved by a law or a rule. It just adds more administrative burden, but it doesn't really solve a problem, because that's a character thing, not a, you know what I mean? It's just not. That's what we do. It is our job to do that every day. There are a lot
that aren't, though.
So I would say
that's what some do.
People need to file complaints. That's the only way that we're going to be able to get to those specific people that are doing this on a regular basis. That's just what I think.
Yeah, we always have to look at the unintended consequences of a rule that requires notification, because it could spiral into much other things that don't need to be involved. I think the standard of care is what we're looking at. But I do think you're right. Pharmacists need to say something, especially in the situation you described. But I just get very concerned about requirements for that. They add another thing for the pharmacist to have to consider, but it should be a standard of care that we should look at.
I think there's something there that actually somewhat addresses this. Just depends on, again, like you mentioned, a narrower scope, but I was actually
Pull
reading
your
it
microphone
broadly.
a little bit closer to you, Randy.
That's the first time I've been accused of not being loud. All right. Thank you, Julie. So there's a statement up. So basically you have 2A, pharmaceutical care services, starting on line 297. Then you got the drug regimen review, and it says, hey, for, you want to make sure it's therapeutically appropriate. Here's all the things. And then 312 actually kind of addresses this possibly. Upon identifying any clinically significant conditions, situations, or items listed in clause 1 of this subparagraph, the pharmacist shall take appropriate steps to avoid or resolve the problem, including consultation with the prescribing practitioner. Doesn't necessarily mean that they're going to contact the practitioner, but maybe they're able to resolve it without direct communication, is the way I've always kind of interpreted that. So I feel like that's captured there. But that's like one specific situation, right? Like what about the other things that Rick was talking about? And do we need to account for those, or are they? I mean, I agree. I think that when it comes to the disciplinary action, I think that's one of those things where it's like, why didn't you contact the prescriber, and why did this patient go 2 days without an antibiotic or what have you? But yeah. So I feel like that circumstance might be covered. I don't know.
Yeah, it sounds like it. But what about when a pharmacist just refuses to fill a drug of any type for personal reasons, religious reasons, personal reasons? No one is getting that medication from them. I mean, I think that there are a lot of other instances, and where's the line drawn with them letting the prescriber know, I'm not dispensing this, it's against my personally held beliefs.
Yeah, so I guess it depends upon what it is, because most of us have policies that if I'll just use Plan B, if it's against their beliefs to ring out or to provide Plan B, it's required that they know of a pharmacy that will, and so they automatically refer the patient to that pharmacy.
Okay.
So
how is like just thinking of all the scenarios, like how is it currently handled? I guess it's probably the same kind of deal where it's managed by PNPs for like if a drug isn't available, because we don't have anything like in rules with that, right? So like,
no, and that's probably one of the biggest I don't want to say issues, because that's not the right word, but often pharmacies are thrown into situations where they've hit their threshold. So for the rest of the month, they're not going to get this class of drugs in. And so in that case, they're not able to fill it, and they'll need to either notify the physician so that they can send a new prescription in or be able to transfer it. And I think that's where a lot of angst comes in, is the fact that thresholds are set. It's the pharmacy doesn't have really visibility until it doesn't come in, and the first time it doesn't come in, they're like, okay, well, it'll be here tomorrow, because they think it's just the wholesaler's out. They reorder it, and then it's, oh no, I've hit my threshold. But now we've told the patient it'll be tomorrow, and now it's not in, and I don't have it, and I can't get it, and so it's just this terrible situation. I mean, it's necessary. It's part of business right now, but it does make it a difficult situation for both sides, for the pharmacist as well as for the patient. And that's where the patient has to then go and, in some cases find who has it and where it can be transferred or where they can go.
So if it is going to be allowed now where prescriptions like that can be transferred, then that kind of eliminates the need for this, I believe. Because that's where my concern came from, is if a prescription dies at a pharmacy, how does that patient get care if the pharmacy doesn't communicate with the prescriber so that the prescriber can take action. Because telling the patient creates awareness, telling the prescriber creates action. And that's what I was kind of looking for. But if any prescription, all prescriptions, 100%, can be transferred to a different pharmacy, then there's no reason for this.
There's still rules that can only be transferred one time. So if they transferred it in, they can't transfer controlled substance out. So there's still regulations, but that's where, you have to pick up the phone. You have to make some phone calls.
And see, okay. Well, there's at least a pathway there. I mean, if it can't be filled somewhere, I think that someone would pick up the phone and make sure the pharmacy that they're going to have it transferred to can fill it before they have it transferred, because they just went through it. I know I would.
And the great thing is each one of our pharmacies has, we believe in making sure we're taking care of the patient and protecting them. So each of our pharmacies has a complaint poster in there. If there's ever an issue, we want to hear from the public so that we can investigate.
It doesn't help you on the day that you're standing there to get your prescription, though, unfortunately, which is where my concern came from. The complaints, handling things, looking into things later, doesn't help you day of. But again, if they can be transferred, then that alleviates my concern and the large part of the basis for my asking for this.
Well, and I think the good thing is that, as Randy pointed out, it is in there. And as far as the, reaching out to the physician, maybe we do look at some additional education, to put on the webpage and get that out there so that pharmacists are looking at it.
Is there anything patient facing that would be helpful? So that they know their options. I know we have certain mandatory language that's up. I can't recall any of it off the top of my head because, yeah.
I don't know. Do you, Megan, Iman, John, do y'all know?
I'm not sure I understand the question.
So what we're looking at is, communication's the key to really everything in our world. And so, one of the things is better looking at, re-emphasizing pharmacists having, a relationship and talking to physicians. Mm-hmm. But what Randy's saying is on the webpage, do we have something that that's patient facing that says, if you can't get your prescription, here's steps to take, or...
I know we have a section of our website dedicated to consumers. I don't know everything that is on that page of the website. We could certainly look into it and see if it's covered or not.
Okay.
I was just going to make a comment on the healthcare side. I mean, you have to be your own advocate. The patient does. And if a prescription is not being filled, you got to find out why. Like Rick said, there's multiple reasons why it's not, but sometimes it's because you call in the prescription number and it'll say, okay, when you want it, it'll be ready in whatever 2 days, but it's not ready. It's because the refill has expired and the doctor's not going to dispense new ones until you go in there and see them. And because of no one wants to pay $150, to get a refill on prescriptions, so they won't do it. So again, it's tough, but those are the problems I hear on the healthcare side. You have to contact your physician to get that refill, because I know the pharmacy will do it, but they'll just reject it.
No, I appreciate that. Thank you. I was originally talking about language when it's the pharmacist's decision not to fill. Was kind of my thinking that if the doctor called it into the pharmacy across the street, that pharmacist would, likely be able to and choose yes to fill it. That was kind of my thinking with this. Or if it's a safety concern and like drug interaction or something like that, to maybe educate the doctor, hey, this is not good. There's drug interaction, and give the doctor options. Just part of that working jointly together. But again, I think we're good. So I will make a motion that we not adopt the proposed rule change.
Yeah, it was actually just a discussion item.
Discussion.
So yeah, so we don't
Right,
need a motion. But
okay.
All
Thank
right.
you.
Sounds good. All right. That will take us to F. So, Caroline, do you want to take us through enforcement?
Yes. So F.1 is the report on the closed complaints from the last quarter. So this was as of the end of February. You have your complaints at the top of the chart that were closed without disciplinary action, and the bottom chart, bottom part of the chart is those closed with disciplinary action. It compares for those complaints that were closed in the first quarter, and then at the bottom there's a kind of a cumulative total of year to date. And then the open complaints are on the next report, F.2, and the top chart is historical data, and then chart 2 is in the far right column, the age of complaints as of April 21st, 2026.
All right, board members, do you have any questions for Caroline? All right, seeing no questions. Thank you, Caroline, for you and everybody in enforcement. All right, Megan, that's going to take us to G, to our disciplinary.
Okay. So you all received the information associated with the items under G in a link prior to this meeting. The information has also been put on your laptops. These are all of the agreed board orders, default orders, and remedial plans that have either been entered or are being proposed to you. G.1 is a report on all of the orders that have been entered by Danny as the executive director. These are only the ones that you have authorized him to enter. This item does not need a vote and is just for your information. If you don't have any questions on these, we will move on to the next part. Be G.2 and G.3. G.2 are the proposed agreed board orders and default orders, and G.3 are the proposed remedial plans. These include both orders and remedial plans resulting from informal conferences and those proposed by mail per your previous instructions. You'll notice the orders resulting from an informal conference. For those, the chart indicates the board members that were at that informal conference. If you participated in the informal conference, we would automatically recuse you from that vote. So unless you have any questions about these, we would need a motion to approve the proposed agreed board orders and default orders and the proposed remedial plans. So that's both items G.2 and G.3.
Any questions, board members? Do we have a motion to approve? I have a motion to approve from Donnie and a second from Rick Tisch. All those in favor? Motion carries. All right. That will take us to H on the agenda. I do want to go ahead and recognize the fact that Orrin Peacock, who was an honorary president of NABP, a member of the Texas State Board of Pharmacy, and held numerous offices during his tenure with the board, has passed. And we wanted to recognize him and thank him for his service. And we'll take just a moment of silence. All right, thank you. That will take us to H.1. And board members, are there any items to look at to be placed on the agenda for August the 4th? Seeing none, we'll begin putting that agenda together. So as far as upcoming conferences, we did mention NABP is next week. We'll be attending that. We do have informal conferences on May 21st, June 2nd through the 3rd, and July 14th through the 16th. Danny and I will be at the Texas Pharmacy Congress on June the 4th and the 5th. TPA will be in the Woodlands, July 24th through the 26th. And board members, make sure it is on your calendar. Our next board meeting is August the 4th. The year is speeding by. And with that, if there is nothing else, I will take a motion to adjourn. I have a motion to adjourn from Haysha and a second from Randy. And with that, we will show this meeting of the Texas State Board of Pharmacy has adjourned.